Okay, great. Let me record as speaker. Okay. So I'm Jen Vendetti, joined by the great Wendy Mohr, and Wendy and I work together in a committee in Postpartum Support International Connecticut chapter called Resources and Professional Development. So Wendy's the chair and I'm in the committee, and we have a multidisciplinary group, and part of that committee really worked on this presentation, including in OBGYN doc, of course, nurses, social work. And so I hope that this will be a meaningful training. Okay. If you're not muted and you're not Wendy or I, go ahead and mute. And I'm going to share my screen, and you're going to let me know if you cannot hear or see my screen, okay? We will get started. I'm going to do a little bit of introduction of perinatal mood and anxiety disorders. And what I want you to be paying close attention to as we move through these more introductory slides is to be thinking about resources that are already part of the way that you practice in nursing or social work if the social worker is able to join. And we're going to use case composites to help us to be thinking about different resources and, referral supports and treatment for our perinatal help seekers, okay? So this is Beyond the Blues, addressing perinatal mental complications in nursing, midwifery, OB, social work. This is a talk that can be applied to across disciplines. And let me just check one more thing. I'm going to hide the video panel. There, okay. I want to record maximum. So we're going to talk about risk factors, symptoms. We're going to use the case composites. We're going to talk about treatment modalities and resources. We want to introduce you to Postpartum Support International. We're talking tonight about this period of time that's pregnancy, postpartum first year, but advocates would like that extended to postpartum, because there are a couple of ripe times, couple of touch points, if you will, beyond the first year. Some of that has to do with the development of the emerging toddler. Some of it has to do with stopping breastfeeding, but there's some touch points in the second year postpartum that can trigger some of these symptoms that need to be addressed, and really can be addressed through psychotherapy, support group, and medication if necessary. We're talking about a disruption or a change in the perinatal person's mood, right? And that could indicate a depression, a bipolar mood disorder, or psychosis. We also often see during this time, it's a very vulnerable time for mothers, anxiety, first episode of a panic attack, obsessive compulsive disorder, and PTSD, and it's interfering often with bonding, with the mother's experience, right? Her emotional experience in connecting with her baby or toddler. And it can also have other disruptions to other aspects of her life, relationships, work, etc. Okay. So this is the list of disorders that clinicians who are evaluating moms are going to be thinking about these conditions in terms of their constellation of symptoms. However, in the Diagnostic and Statistical Manual, DSM, there is a peripartum specifier that can be used on these PMADs, but it can only be used when the woman is pregnant at 6 months or all the way through, so 6 months of pregnancy, postpartum, just the first 6 weeks. So it's not really, we're not really doing a great job at providing the opportunity for clinicians to use perinatal specific diagnostics. Okay. And so that's a piece of the research, the advocacy, and the policy work that needs to be done. We can categorize risk factors by biological, sociocultural, physical, psychosocial, and psychological risk. And thinking about the perinatal people that you have worked with over time, you can see when you are noticing some changes, or you get a call on the unit a couple days post-discharge and you're hearing what's happening for this mom, you're thinking about what the labor and delivery course was like for this mom, what the postpartum course was like while she was with you in inpatient. And you can see that sometimes there can be sort of a perfect storm, if you will. Now add in that I may be coming into pregnancy and birth and postpartum with an abuse history, with a trauma history. Maybe there's no support system. I have socioeconomic challenges, right? And we know, of course, because we know about newborn babies, we know how they sleep. We know what their sleep rhythms are. Very different from adult sleep rhythms. So we know that that can put moms at risk. And of course, now we are parenting in this sociocultural environment that puts so much pressure on all of us in so many different ways. And we won't go into a lot of detail about that because we could talk the whole time about that, the pressures of parenting now, right? So these conditions are really almost expected in a way when you think about all of these risk factors. ACOG and of course many other leading organizations dedicated to well-being and mental health have all agreed that we need to be screening during pregnancy, particularly in the 3rd trimester, and postpartum. And that we need to come up with protocols and practices and workflow that enables us to have conversations with perinatal people about their emotional and psychological experiences. And we need to be prepared to connect them with resources through our hospital systems and or the community. The reason that we are so concerned about when we leave depressions and anxieties untreated is the consequences for the mom and the consequences for the baby. So about 30% of women are going to enter into pregnancy having history of depression or anxiety. And about 30% of women will start to develop some of these symptoms during pregnancy. So that means accounting for those coming into pregnancy and those in pregnancy, this is a time where these unmet clinical needs could be a cause for miscarriage, preterm delivery, fetal growth restriction, low birth weight, and hypertensive disorders. So it's very important that we're addressing mental health during pregnancy. And of course, if we can, before pregnancy. And postpartum, yeah, if we leave these illnesses untreated, we could see an even more persistent depression. We could see suicidal ideation. We could see a waxing and waning of postpartum psychosis symptoms. And certainly, we may see interference with bonding. So for the infant all the way through adolescence, there can be consequences if we are not treating depression and anxiety. I'd like to play this video. I think we can spare the time. This is an important look at the inner experience.
I've made a mistake. I'm no good. I don't want to do anything. My baby, she'd be better off without me. I'm a failure. It would be better if I was gone. What am I saying?
Does not want to let me go full screen. Okay. Let's see if I can go. There we go. Okay. Okay. Try again. Let me know if you can't hear or see the screen.
I'm a terrible mother. What if people find out? I've made a mistake. I'm no good. I don't want to do anything. My baby, she'd be better off without me. I'm a failure. It would be better if I was gone. What am I saying? That's crazy. Something's wrong with me. I can't do this anymore. All I wanted was to be a mom. All I wanted was to be a mom. I don't feel anything. I'm nothing. I'm empty. I'm a robot going through the motions. I can't give up. I can't go on. I want to die. All I wanted was to be a mom. All I wanted was to be a mom. I'm so alone. My baby deserves more. I'm nothing. I'm empty. I'm empty. What if I let the stroller go? What if I drop her? What if I do it on purpose? Oh God, what's wrong with me? I'm crazy. I'm crazy. All I wanted was to be a mom. All I wanted was to be a mom. How much milk has she had? She's starving. I'm a terrible mom. 10 ounces in the morning. I'm empty. How many diapers has she filled? I have to clean the house. I have to clean the house. I can't sleep. I'm so tired. All I wanted was to be a mom. All I wanted was to be a mom.
Even with all of the work that's been done to address awareness, stigma, developing treatments, training providers, still we see only a percentage, a small percentage of moms who are receiving treatment for perinatal mood and anxiety disorder conditions. So there's so much work to be done. Now, if we were passing this mom in that pathway here, we'd say, wow, she looks great. She's walking her baby, right? She's interacting with her baby through walking. She's getting outside. Maybe she would even smile at us. You know, maybe we would stop and say, oh, look at your baby. What a beautiful baby, which would be a nice thing to do because postpartum people need feedback from the environment. That's part of the work that we all do, right? Notice the baby and give feedback to the parent. That helps to develop their sense of pride. It helps to develop their identity as a parent. So, you know, maybe we stop, we have a little conversation. She smiles, she seems like she's enjoying herself. But we don't know that that's her inner experience, do we? And that's why that video is so powerful, because it really tunes us in to what the ruminating, just what if experience many perinatal people have. And it really interferes. If that is what's happening in your mind throughout the day, it's going to interfere with how you experience postpartum and how you are able to negotiate this new role and how you're able to cultivate attachment with your baby. And that's so important. And every perinatal person deserves that opportunity. So moms might not even recognize that they're experiencing depression because a lot of times you will see anger, irritability, rage, even. You'll see anxiety, just difficulty sleeping, feeling really, keyed up, on edge. And so many moms may not recognize that those are classic postpartum depression symptoms, right? And the scarring part of these illnesses are the guilt and shame. And though that symptom can occur, those symptoms, I should say, can occur during the experience of depression and anxiety, but it can also last for a lot longer after mom is largely recovered. And of course, we can understand that we will see this often when moms have to take some time for their recovery and healing experience. Okay. That could mean a more intensive treatment, right? Like a partial hospital or even inpatient. And so our work is really trying to reduce any possibility of trauma, of the shame, of the guilt, and just normalize, destigmatize, provide education, get moms connected. And hopefully in the future, we will see in Connecticut IOP, PHP, and inpatient that is actually specific to mothers, right? Specific to pregnant and postpartum people. And we do not yet have those specialized resources in Connecticut. So the screen positive prevalence rate, this has been replicated many times, is generally about 15%. So that's what we can expect. And I think that's helpful because you can look at your own, how many babies are delivered at our hospital each year, and you can do some number crunching, right? It's about 15% are going to screen positive. And the rest of these data that you see here from Kathy Weisner's classic study of over 10,000 women in an urban Pennsylvania community. And so she wanted to look at the EPDS, the Edinburgh Postnatal Depression Scale. She did that. She wanted to see how sensitive it was. She wanted to see what her screen positive rate would be. So it was 14%, took those 14% women, brought them into the clinic for a psychiatric diagnostic interview, and 91% of those screening positive did meet criteria for an Axis 1 mood diagnosis. It was mostly depression, but 23% were found to have bipolar depression. And then again, we see this 30% starting their symptoms during pregnancy. About 30% we feel will start these symptoms postpartum, and then about 30% are coming into the pregnancy experience with some symptoms of depression or anxiety. Almost 20% endorse thoughts of self-harm. So we always have to be attending to suicidal ideation. And of course, many had comorbid anxiety as well. Now, Kathy was using a screen cutoff of a 10. In our home visiting programs, we use an 11. Okay, so you can use different screen cutoffs depending on how many, what your resources look like. Okay, so the prevalence rates of perinatal depression for all women is 15 to 20%. For low income moms, it's 40 to 60%. And then Bob Ammerman has found between 29 and 61% of moms who are enrolled in an early childhood home visiting program are experiencing perinatal depression. And we really must attend to these conditions because in the work that our Connecticut Maternal Mortality and Morbidity Committee Mortality Review Committee have found, as in the cases of maternal death in Connecticut over the course of 2015 to 2019, 44% had underlying mental health conditions. Okay. Also could be comorbid with substance use disorder as well. That would be included. So this is part of our work in addressing maternal mortality and morbidity. So the CDC, their response was to create a campaign. It's called the Hear Her campaign. And it's important for us in hospital systems to just always be thinking about the ways that we are seen and our ways of being when we're working with patients. Do we seem emotionally available? Are we listening, right? And it's very, very challenging in healthcare systems because the system itself is not designed to give you, the providers, enough time with your patients. So we have system level barriers that then can lead to provider level barriers. But listening is going to be the philosophy, the stance that we're going to take. Okay. When we think about the different treatment and care, options for perinatal people, this is what we're thinking about, right? Psychotherapy or talk therapy is going to be our frontline treatment for most of the PMADs. In most cases, we'll be talking about a mild to moderate depression or anxiety. And I put under here independent practice and psychotherapy groups. Independent practice refers to the workforce in the community of psychotherapists that have their own practice or their own group practice. Okay, some, of course, work in groups. And the reason that we put this here is because in Connecticut, we have a very, very strong private practice workforce. And it's this workforce that has been most attentive to becoming specialized in perinatal mental health. So oftentimes we want to be, building our resource guides, thinking about that workforce, because oftentimes, and you can, if Midstate has behavioral health clinic, you can look at what their protocols are. You can talk to them about whether or not they want to have a perinatal specialized clinician on staff. That would be like the go-to person so that you could make referrals there. But sometimes we see with clinics that the intake process might not be responsive to the perinatal person and what their special needs may be. So the intake may be done by one person, and then the actual psychotherapy piece may be done by a different person. And we want to eliminate that, the mom having to tell her story to multiple people before getting treatment, right? We also want to make sure that the baby is at least invited to be a part of the work because of childcare barriers, because of breastfeeding. We certainly want to have a breastfeeding friendly environment. We certainly want to have some toys available if we have an infant toddler in the session. And the therapist must be trained in some of the really salient issues surrounding the perinatal person, right? Perinatal loss, birth trauma, assisted technology for pregnancy, bonding, right? Development of the infant, etc. Psychotherapy groups are very hard to find. There's not a lot of them, although many clinicians do try to start them. But of course, as you can imagine, trying to get, a group of perinatal people to come together at the same time to engage in group psychotherapy is challenging. But that's the psychotherapy piece, okay? Support groups in perinatal mental health, support groups in breastfeeding, support groups in perinatal loss. They're not necessarily plentiful, are they? And, you can think about whether or not you've got a breastfeeding group going there. I know when Wendy and I did a talk with HOCC, they've got a group that they're doing weekly, and it's a parade of mothers and babies going to that group every week. And that's really wonderful, but we don't see that necessarily in every community. PSI Connecticut on our website does list groups. There's not lots and lots and lots of them, but we do list them. And then Postpartum Support International has over 45 free online support groups happening every week, and an array of groups happening in Spanish. Perinatal loss groups we'll find through Hope After Loss, and that is an organization right here in Connecticut. Parent-child interaction groups, sometimes also challenging to find. Infant massage groups, is that something that can be offered through the hospital system? Play groups, parenting networks, and family resource centers. Medication therapy may be a complement to psychotherapy, may be a very important first step treatment for a mom that's not sleeping at all, having panic attacks. Right? Certainly, we will see medication therapy be necessary if we're seeing some psychotic symptoms. Right? Hartford Hospital Peripartum Mood Disorders Program is the only outpatient specialized perinatal mental health clinic in the state of Connecticut. They do medication evaluation, and they do have some psychotherapy, and they also have some psychotherapy groups run by their perinatal social worker. We see now more psychiatric nurses coming on the scene in private practice and becoming specialized in perinatal mental health. That's very exciting. And more OB and primary care practitioners are feeling comfortable with frontline SSRI medications. And then we do have a statewide home visiting system. That's early childhood home visiting. We also are seeing a burgeoning doula workforce in the state of Connecticut, and hopefully DPH and DSS are going to work through all of their processes to have the doula services reimbursed. That will make them more accessible. And childbirth education. What does your childbirth education look like at your hospital? Are there other components to childbirth education that you can add? And are you talking with families about perinatal mental health? If you are, and let's say you're doing the class virtual, or you have the screen behind you and you're in the classroom, are you pulling up Postpartum Support International, letting the perinatal people know about these free accessible resources? So these are some of the things that we want to support you in thinking about. Okay, let's go to our first composite. And for the case composites, you can either unmute or you can use the chat. And what we want to be thinking about as we read through these mom stories is, what resources would we be thinking about for her? Okay, we're thinking about the resources. So Danica is a first-time pregnant mom with a history of depression and anxiety. She has concerns about medication safety. Now, we didn't talk, there's other resources we have not introduced you to. So they might come into your mind and they might not, and that's okay. We're going to talk through them. So she has concerns about medication safety. She's currently taking Zoloft, right? She's pregnant, she's worried about that. Is that okay? Is that okay to take? She has a history of sexual assault and trauma sequelae. She's biracial, she's low income, and she does not have good partner support. Now I don't have any Zoom controls. Okay, let's see what happens. I try to get you back. Okay, here you are back. And I stopped the share, did I not? Did I stop the share, Wendy? Let's see. Yeah, I did. Okay, good. Okay, reflections, resources. What are we thinking about? What do you think might be helpful for Danica?
She might be eligible for like a doula, like the doula service, to have a doula.
Yes, because we're thinking about she has a history of sexual assault. Birth might be a triggering and or traumatic experience for her. So some extra support around the birth process. Excellent. Anything else we're thinking about? She's pregnant, she's low income, she doesn't have good partner support. Another reason why we're going to think about doula, right? Because she might be alone in the delivery room. Yeah.
Just making sure that she continues the Zoloft after, I mean, she's high risk already because she's got the history of, and she's already taking the Zoloft. I think sometimes the OBs kind of either don't look at that or like they forget, and it's not followed through until like there's an episode later, or when she's postpartum, and nursing is like, hey, she was on Zoloft, you better, and says something.
Yeah, that's important. Continuity of care, making sure that she is not, that she has medication, and she can continue to be prescribed sertraline as a breastfeeding woman as well. So, yes. And someone says community health centers have assistance for low-income patients, and they have a psychological office there. Yes. Now, what we want to be aware of is, as I talked earlier, sometimes we see in a health center or clinic-based outpatient services that they may not be specialized in perinatal mood and anxiety disorders, and they may not be responsive to some of the needs that perinatal people have. Okay. And again, that can come through in the intake process. So that's going to be important going forward as a state, thinking about how we can address some of the clinic-based outpatient psychotherapy services. Making sure that the intake and the therapy is going to be provided by the same person. My experience in my area with community health centers is the baby may not be allowed to attend the session at all. And that could be a barrier for the mom being able to get services there. Okay. So I really want to see hospital social workers getting connected to these specialized therapists in the community. But thinking about what else might be available, connecting her with support groups, new mothers groups, lactation support. Yes. Yes. Now the doula can provide some childbirth education, but hospital-based childbirth education. And then what else? What was the array of services that I said that I work with? Anyone remember? I'll share my screen again so we can go back to the slides, but hopefully my chat will stay up. Oh, okay. I guess I'm still sharing. Okay. I'll let you, Wendy, monitor the chat because once I have my screen up, it takes away the chat. So I'm like, yeah, perfect. Okay. So just to keep us moving forward, because of time, I'm going to keep going and I'm going to show you what we were thinking of when we built this composite. If I can advance, here we go. Okay, so we didn't talk about this, mother to baby. What's that? So mother to baby is a program of the Office of Teratology Information Specialists, OTIS, which is a national organization. And they have a free statewide service. And that service is for both providers as well as patients or consumers to get risk-benefit information about any teratogen during pregnancy and breastfeeding. So it's a very, very specialized service. And so the genetic counselors or the teratology information specialists that are providing the information are really well versed in all of the literature available for particular drugs or teratogens, focusing in on pregnancy and breastfeeding. So it's a really cool resource. We'll be sending a PDF version of this presentation. So you'll see Mother to Baby has a slide here so that you can get all the contact information. There is also now Access Mental Health for Moms here in Connecticut, which is a psychiatry consultation service, and that's just for providers. But let's say this provider, had questions about which medication to prescribe, didn't know if sertraline was okay to prescribe during pregnancy. The provider could contact Access Mental Health for Moms. So we have mother to baby. We can give that to the mom because she has concerns. So it might help give her some relief about taking this medication if she hears from a specialist that it's safe. Okay. Home visiting. We should absolutely offer Danica home visiting. She's pregnant. She's got low support. The home visitor is a parent educator that can go to her home every week for an hour or so. The home visitor can provide some childbirth education. The home visitor can also connect her to doula if that isn't already connected through the hospital, right? Some of the home visiting programs have subcontracts with doula services. So Danica might not be able to afford a doula, but if she goes into home visiting, she may be able to get connected that way. Okay. The parent educator will support her work with bonding. This parent educator can provide instrumental support, and the parent educator can make linkages. Home visiting programs screen. So let's say, she's seems to be doing well. Now she's discharged. But if she's in the hands of a home visiting program, she'll continue to be screened and monitored. And if she needs additional services, doesn't say she has psychotherapy. So she might need that, right? And the home visiting program can connect her if she doesn't connect with psychotherapy during pregnancy. Here's the slide on mother to baby. The outcomes of working with a doula. And now we have Stacy. So Stacy is doing her appointment 6 weeks postpartum. And her Edinburgh is a 9, right? So, we said in Kathy Weisner's study, she used a 10, home visiting, we used an 11. This is a 9, so a little below this positive cutoff, right? But the provider says, Are there any thoughts that are upsetting you? And the mom shyly reports repeatedly seeing herself and her baby falling down the stairs. Wendy and I said we were going to change the question of whether it's normal or abnormal. We're not going to use that. What is this phenomenon? Is this a common phenomenon? Have you heard of this? She pictures herself. She has an image, comes into her mind, and in the image, she's falling down the stairs with her baby. What is that?
Yeah, Melissa in the chat said intrusive thoughts.
Well done, Melissa. You know
Yeah.
a lot about PMADs. Good. So Karen Kleinman, who's written extensively about perinatal mood and anxiety disorders, wrote this book. Let's see if I can get it. Dropping the Baby and Other Scary Thoughts. And it's quite a good Bible on the topic. Mothers can read the book, providers can read the book, but it's a very common experience. Now, she may also be experiencing depression or anxiety, or even meet criteria for obsessive compulsive disorder, but she may not. I mean, she may just be experiencing, this symptom. And either way, these intrusive perinatal scary thoughts or images can be addressed through psychotherapy and or support group. But they're very important to address because usually what the brain wants to do is say, like, avoid. That's not happening, and we just try to just put it out of our mind. But when this is happening, it's like an alarm going off. And it's like we're snoozing the alarm. So they keep coming back when we don't address them in the right way. But we can normalize and we can provide education. We can say to Stacy, this is common. You're not alone. And if she says, why is it happening? We can say, because the brain is primed for this sort of transient OCD. And those are not my words, but those are the words of James Swain, James Leckman, and Linda Mays, a Yale research team that has done fMRI data on the brain of pregnant and postpartum people, men and women. And they have seen that the areas of certain areas of the brain are really lit up. Guess what areas those are? Amygdala, fight or flight response, right? And the areas of the brain that are a little bit more dimmed down, those who have had children in the room are going to say, oh yeah, mommy brain, right? All the prefrontal cortex, that's what's dimmed down. So executive functioning, organization, planning, that's what's low. But this fight or flight response is high. So you can say, Stacy, this is your brain on pregnancy. This is your brain postpartum. And that's going to be very important. In addition to having books like Karen Kleinman's, it's good to read stories from mothers' own experiences. And A Dance in the DSM was written by Jess Como, who lives right here in Connecticut. And she talks about her lived experience with anxiety, OCD, and depression. So we want to provide some psychoeducation. Psychotherapy is a perfect idea and support group. And when we're thinking about these, and we're not treatment providers of the PMADs, but it's good for us to be aware of this, is that it's not what she says the thought is or what she says the image is. It's not sort of the nature of it. Because some of these thoughts and these images can be quite upsetting, and they could involve blood or they could involve harm even to the baby, because that's the nature of these kinds of things. Okay? The differentiating factor as to whether we're concerned about her in terms of her sense of reality, in terms of whether she might harm the baby, is whether or not she is suffering and she's aware, right? In the case of Stacy, she's shyly, right? She's like strategically reporting this to you. She's quite aware. She's quite aware that you know, she doesn't know what your response is going to be. Am I crazy because I'm thinking this? So she's aware, and perhaps she then starts to cry, or she says, this is really scaring me. I don't understand this. That is the ego dystonic presentation of the perinatal scary thought. So there's little to no risk of harm. She's reporting this because she wants help. And this is really making her uncomfortable. It's really interfering with her experience. Versus a mom who is presenting where she's just communicating these thoughts and images as if it's really nothing very significant. And, you know, perhaps talking about taking a next step, and that somebody is perhaps encouraging her. Okay. And so that's the distinction. But mostly what we would see is an opportunity, and we talk about this in our prenatal parenting, because it's a good time to say, sometimes we experience these things, and to start to normalize it through psychoeducation. A lot of shame and fear with these perinatal scary thoughts, and they're so common. In that slide, you really see that in the fMRI data, well, Jonathan Abramovitz's work was 91% of moms and 88% of dads experience obsessive thoughts post-birth. And then the Yale folks found 95% of moms and 80% of dads experience OCD-like intrusive thoughts pre-birth. So it's very common. Whoops, going the wrong way. Okay. And this is a way that we can distinguish between intrusive thoughts and psychotic symptoms. In psychotic symptoms, where we know that moms are at high risk for not having control of their actions, women are not recognizing that their actions or thoughts are unhealthy. They seem to have less anxiety when they indulge in the thoughts. Whereas with the OCD-like thoughts, when they come into a woman's mind, it's really giving her a lot of anxiety. Okay? We see delusional beliefs, may see hallucinations, right? So these are like images that the mom is saying, this is happening, it's real, and she's in that hallucination. We're going to do one more case composite. I'm going to do a different one, but Carmen, we can see here, could use a provider consult because she's taking sertraline, but she's having side effects. So if she goes back to primary care OB, they may not know what like a next or a different treatment could be. And so they may need some guidance on that. Okay. And that could be through Access Mental Health for Moms, which is here in Connecticut. That could be mother to baby. Or that could be the PSI psychiatry consult line. Okay. Medication, psychotherapy, perinatal support group, because her self-esteem is low and she's symptomatic. And she needs support with breastfeeding. Okay.
Jen, a question
ma'am.
back a couple of slides. Do we have a list or information about the home visiting services?
Ah, that's an excellent question. Okay, so
Yep.
the best way, I'll have to see if we do have a slide, but the best way, whoa, wait a second. Here it is. Okay. There's a couple of different ways. I got to think about for Midstate who your primary contact should be. That would be a really good idea for the social worker to have like one or two primary contacts, like who is covering Middlesex County and, you know, Upper New Haven County for you. That's going to be really important. But there is a map. So sometimes programs will contact me and I'll use the map to give me some direction. And that's an interactive map down here. So if your mom, you know, she lives in Cheshire, what would be that program? She's in Meriden proper. That could be Hospital of Central Connecticut. It could be Wheeler Clinic. I think Esther would be a good, and so if the social worker is not on this call, I want to talk with her because I can give her that information. We can talk about early childhood home visiting and I can do an email connection with her and definitely will be Esther, will be, want to see who else. Hi, thank you. There's programs all around the state. And so
Jen, is it, I'm sorry to cut you up. Is it, I was the one that asked the question. Is it difficult to get the home services into for them? Or, you know, like, I feel like it's difficult sometimes with insurances to get regular home care. So like this kind of home care, is it also difficult or is it a little bit more, or is it a little easier to get?
A little bit more accessible, yeah.
Yeah.
Okay, so early childhood home visiting under the Office of Early Childhood, of course, is grant funded from state and federal money. So there's no insurance, you know, there's no fees, of course. The capacity right now, I would say, is that if we have expectant parents who are experiencing environmental stressors and can benefit from having a parent educator in the home, we can usually get that family into home visiting. However, we've got 35,000 births a year in the state of Connecticut. Can they all get into home visiting? No. And we do have a movement of nurse and community health workers doing universal home visiting in two areas of the state. They're not in the Meriden area, but so what I'm saying is I think we're going to see more and more capacity. If we have a 19-year-old prenatal mom who is a woman of color and has low support, absolutely, we're going to find a spot for her in home visiting. Okay. So when we see need, I think the home visiting programs are doing a very, very good job at responding. And the ease of getting into the program should be pretty good as long as we have some contacts. And the social worker should be able to just send a quick email, like, do you have an opening? And then what's your referral process? Is it encrypted email? You know, I think that's, yeah. That's a really good protocol that if you're finding, Terry, that it seems complicated, we need to address that. We absolutely need to address that.
I'm gonna I'll hook you up with our social worker. I'll have her email you. She's not currently on this. And I don't know what I was thinking. I would have really asked her to log on. But
that's okay,
that was a miss on my part. But I think that
I can have a one-on-one. We can have a one-on-one. And it will be great because and ultimately, as the nurse leaders are collaborating around perinatal mental health and having these trainings, ultimately it would be great for all the Hartford healthcare social workers to also have sometime, even if it was on a quarterly basis, to come together and talk about what works and what doesn't work. And sometimes it's just a matter of making those connections so that she feels like she can have a nice, smooth pathway into home visiting. That's really important. And it's so great when the mom comes for delivery and you know that she is home visiting, because you know postpartum, she already has support. Yeah, because it's true. We lost postpartum home-based nursing care. I mean, we lost that decades ago.
I think it needs to come back.
It definitely needs to come
It
back.
really does. They're not
It really
prepared to go
does.
home. They're
No,
just not.
no, and that's
I don't know
why,
how these babies do it. It's a wing and a prayer.
well, because the time, in the hospital is so short now. And you're right, there's a lot of post-birth education that needs to happen. And we know that even we might have great childbirth education programs at our hospital. How many of the birthing patients are accessing them? Maybe 30%, maybe even less. So yeah, that education from the doula, the home visitor, and the nurse is going to be instrumental. So the universal home visiting program, which uses a model called Family Connects, is a nurse model. So the nurse is going to be able to address maternal mortality by doing physical checkups, right? Checking that incision and being able to do some of that, physical well-being care right there in her home. Yeah. And I think I talked to Family Bridge earlier this week, but there was a report that came out on NPR about how they were doing. And since last October, they saw 818 families in the home, the nurses. So that's really encouraging.
Wow.
I'm not going to do more case composites, but suffice to say that in all of the case composites, we're talking about resources such as home visiting, psychotherapy, support group, having access to mother to baby or Access Mental Health Connecticut if the mom is on medication. Now, of course, we couldn't do a case composite on what happens when we see really some of these psychotic symptoms that can come up, or SI, or just a really, really acute anxiety or depression presentation that requires day treatment or a more frequent treatment, because we don't have perinatal specialized resources. We do have those programs, but they're just not specific to perinatal people. Okay. Certainly, birth trauma is something that we want to prevent. But when it happens, and up to 34% of moms report experiencing their birth as traumatic, psychotherapy is a very important part of the resources. I want to introduce you to Postpartum Support International. And if this is not an organization that you're familiar with, we really want to invite you to get to know us better. Okay. So Postpartum Support International was founded in 1987 by Jane Honigman. And with lived experience, Jane really felt strongly that parents needed peer support and group support. And that was the model that she started in California. This organization has grown tremendously since I learned about it in 2012, when there was like a staff of, 2 people. And PSI National has staff, but they also still operate with many, many, many volunteers. And it's volunteers who operate the helpline that Wendy and I were talking about. And the helpline's been around for decades. So help seekers can call or text the helpline in English and Spanish. If they live in Connecticut, they might get connected with me, Wendy, or one of the other 10 of us here. Or they might just work with the helpline volunteer. for some support and for some resources. So it's good to think about giving patients information about PSI because you don't know how someone will do postpartum, and they might come into the labor and the maternity units with just everything is going great and things might unravel. So at least you know you're giving these resources. Now, the United States has a maternal mental health hotline, and that's staffed by clinicians hired by PSI, and the counselors are available in English and Spanish, but with access to 60 languages. There's a whole array of professional services, such as training, and under Get Help, you can see the list of support resources, and they have a whole page of resources in Spanish as well. So these are all of the types of support groups that are available, and they're free. They're national groups, right? So the mom in Connecticut may be there with the mom in Indiana. Okay, that's how it works. But they have groups happening every day of the week, including the evenings and the weekends. So that's exciting. If you are really passionate about this work and you want to stay connected with what we're doing in Connecticut, on the homepage, that's me. That's Representative Kai Belton, Corey Bernard, one of our presidents, Amy Rodriguez, chairs advocacy and policy, and Dr. Sam Smalls is our board secretary. But you just sign up for the email. It's free. And we do a newsletter once a month. We operate our board and our committees, and that's how we're able to have a chapter here in Connecticut. But at the chapter level, we're all volunteers. And, you know, as I said, we're working to just bring awareness and some education through hospital systems and the larger community. Yeah. Okay. Go to your shift if you have to get on shift. Go home if you're ready to go home, but stay with me and Wendy if you have questions or want to talk to us more. That's your notice that this is the official end to the presentation. And we will get the slideshow to you. I know we didn't get to every single slide, but you'll have a chance to go through them. And then there's all kinds of hyperlinks in there.